Hi, my name is Dr. Mark Sell, and I'm talking about what makes for a good therapy session, and this video is going to be on why modern psychoanalysis. And just to grab the viewer's attention, modern psychoanalysis is, one can be in psychoanalysis, one does not have to be in psychoanalysis 2, 3, or 4 times a week. Psychoanalysis is not about probing the mind, making people uncomfortable, analyzing them, which sounds like an uncomfortable thing. Somebody once spoke to me the other day, and I was wondering what her associations were to being analyzed, and she said being evaluated and being sized up. And I think this is the problem with classical psychoanalysis, is that because of the way it was practiced, it gave people that feeling. So I hope to grab your attention, and I'm going to talk about modern psychoanalysis. Freud invented psychoanalysis, and he did some remarkable work throughout the many years that he pursued his interests, and they cannot be discounted. I'm going to move right into modern psychoanalysis, because what Freud ran into was what he called the wall of narcissism. And he could not work with certain patients at that time. He thought that they were untreatable, and he thought that they didn't have a transference. But it was a kind of transference that he was used to working with, which was an object transference, and there was good reason why he couldn't work with them, because he didn't know how to treat them. So that left a big gap in treatment. Many patients at that time were discarded or dismissed as being untreatable, until a man named Dr. Hyman Spotnitz came along and invented a whole new way of thinking about patients' problems and a new way of working with them. His name is spelled Hyman Spotnitz. And the book that he wrote was the Modern Psychoanalysis of the Schizophrenic Patient. He wrote it in first published edition 1969, and the second edition is 1985. And it's a great book. I'm biased, but this is it's called affectionately the Red Book. So you can also buy it in paperback. I like the hardcover edition because it reminds me of the old days. I'm not that old, but I like the idea of the Red Book. So what he found was that patients were treatable. He kept the concept, he was a true Freudian, he kept the concepts of transference and resistance in all of his work, but he did away with interpretation. He had an idea of what caused mental illness, which really fascinated me when I learned about it. And take an infant who's maybe 2, 3, 4 years old, and they have a desire for a piece of candy. So they go to the candy jar and they dip in their hand, and the mother scolds the baby perhaps and says, "Don't take any more candy," and the baby goes back in again because it wants some more candy. And mother scolds the baby again, perhaps a little harsher this time. In a drastic situation, the mother or father might come along and cuff the kid in the head and say, "Stay away from that. I told you not to take any more of that candy. Stay away from it." Well, if this continues over time, this kind of reaction to the baby's needs, it begins to feel, first there's a frustration, and a frustration aggression. It begins to feel also that its voice can't be heard, because the parents don't often want to hear the objections of the child, even though they can scold and criticize and sometimes physically abuse children, but they don't want to hear it. So where does those feelings go? It goes inside. It goes inside in the form of internalized aggression, and there is no outlet. So what Spotnitz found was that the cause of mental illness resulted from this frustration, aggression turn inward, and For instance, in symptoms like depression, you'd have self-recriminating attacks. I'm no good, I'm worthless, I'm a piece of shit, I'm unlovable. Because a child, when its needs are rejected, it begins to feel, it can't differentiate that, well, it's the parent's fault, it blames itself. So it must be, I'm bad because I have needs. That's a hell of a situation to come up with, that I'm bad because I have needs. But that's what happens. In psychosomatic illness, this frustration, aggression can go into skin conditions or ulcers. And in schizophrenia, it can go into thought disorder and confusion. So that was the fate of the frustration, aggression. Now, we often think of narcissistic people as withdrawn, self-involved, but it's really a protection. It's not so. If we look at it as a protection, what Spotnitz discovered was that the self-attacking recriminations are really meant for somebody else. So it's really a disguise. So it says, well, I won't be mad at the object, I'll attack me instead, because it's too threatening to attack the object. So it's a cloak covering the anger and hatred that the child cannot express. So it's a great disguise. It's not a very effective one because it ends up in these different kinds of symptoms, but at least it protects the object in the person's mind, and it protects the self from the fear of losing control, which is a predominant fear of losing control and perhaps destroying the object. And that doesn't happen very frequently in analysis, but at least it's a legitimate fear that patients have. So in classical analysis, the mode of intervention was interpretation. Now, interpretation, Spotnitz's feeling was about it, and I think I've experienced this a lot in my many years of work, is that interpretation, you do such and such because of such and such a reason. First of all, it's like you're talking down to the patient, explaining things. I don't think that's a very good feeling or a way to model a relationship. Also, questions like, why do you do this? Or why did you do that? Or why do you think you did that? Well, a person with fairly severe disturbances, and I count myself along in that line of having these disturbances, as well as my colleagues, as well as the general population. I don't think the schizophrenia doesn't mean that this is just for severely disturbed people, only in the sense that we're all in some way severely disturbed, and in some ways, given certain amount of stress in life, we can have certain reactions like borderline patients have, or severely narcissistic disturbed patients have. But in some way, his theory really, to me, describes what causes mental illness, and it's not a simple theory, but it's a good way to comprehend symptom creation. So interpretations often feel stinging. The person might feel attacked. May not be able to say that to the therapist because they're afraid of alienating the therapist. That's why people don't talk, and we have to help them with the resistance to talk, because the motives for the resistance is our fear of losing the object, or retaliation, or the therapist will throw them out of the office. So it's no wonder people have a hard time coming into therapy, because first of all, they carry these fears with them, and they've been used to judgment. They don't expect to be welcomed and accepted. And also, they don't trust the relationship, and why should they? Feeling questions are also, like we were trained many years ago to ask feeling questions, but supposing somebody doesn't know how they feel, that kind of question makes them feel, what's the matter with me? I got to come up with an answer. I don't have one, so there I am. Something's wrong with me again. So he had other interventions which made the patient and he feel like the patient and the analyst feel like they were alike. Gradually over time, you develop what he called a narcissistic transference, and this was accomplished by different interventions, which I'm not going to go into at this point, but they're like joining the patient. Maybe the person might not feel like they're talking or can't talk, so you say, well, maybe you shouldn't talk. Maybe it's a good thing not to talk. Instead of, why don't you want to talk, or maybe you're too frightened to talk. I had a patient once who came to me and she said, I never came to therapy because I thought you had to talk about the past. And I said, no, you don't have to talk, just come and talk. And a couple of years later, she wound up crying about the past, but that was in her own time, not in my time, my predetermined time that I had because of my agenda. So interventions of a modern analyst are primarily, after a long while, this doesn't happen very short term, but aimed at getting these interjects. The interject is, I'm no good, I'm a piece of shit, out of the ego, and they become part of the ego when you ask why questions. Oh, I'm stupid, I can't answer the question. Out of the ego into the object world. For instance, I was working with somebody who was very timid, and I got her to attack some of the things in my office, and then finally, this was kind of along the process, I might ask, well, how is she experiencing the treatment, and she might be a little bit timid about telling me. So I said, well, all people that I work with have some kind of criticisms of the way I do things, or the office. And she says, well, as a matter of fact, sometimes you talk too much. So that was terrific. She was able to voice some objection to the way I worked. She was using cocaine at the time, and I helped her quit cocaine, and when she quit, she remarked, the more angry I feel, the less of an impulse I have to use crack and cocaine, which was, opioids have an anti-crack function, and so we're talking about frustration, aggression, modern analysis, how it helps people, and what's the basis of the theory. There you have it, A lot of psychoanalysts would never work with people who are using alcohol or crack cocaine. Let's refer them to somebody else. Also, when she quit Prozac, she had a feeling of being more energetic and more ambitious. Now, what are we doing giving SSRIs and handing them out like candy, pun intended, candy, to people, when ultimately, often the reaction is to dull their sense of ambition? One of Spotnitz's major contributions was assuming the responsibility for the treatment. Ralph Greenson, a classic analyst, what was the quote here? He said, the stalemates in therapy, stalemates can't go anywhere, you're stuck, result from the failure of the patient to develop reliable working relations with the analyst. Spotnitz wrote, and he says it's the therapist's responsibility to establish a working relationship with the patient. And if that goes asunder, then the therapist has to look at why, and say, it's me. It's not you. Talking about criticism, D.W. Winnicott. One of the quotes that I loved was he said, "It's joy to be hidden and disaster not to be found." And I like that quote because it's the dilemma of people that walk in our office. They need to be hidden for a while, and they need to be held while they're being hidden and not criticized and not shamed. And also they need to be discovered. And if you're not discovered, no one gets to know who the real you is, because you're so accustomed to giving everybody else what you think they want to hear. Winnicott, D.W. Winnicott, came to talk about criticism, came to it was in the United States in 1968, and this is a quote from the New York Times. He visited the New York Psychoanalytic to present a paper. While his hosts believed that analysts should offer their patients nothing other than concise statements on interpretation, Dr. Winnicott encouraged analysts to seek a warm and affectionate rapport with those in their care. After he delivered his remarks, his fellow speakers unleashed what Freud might have referred to as their destructive instincts. That night, Dr. Winnicott went back to his hotel room and had a heart attack. I don't think he died then, but it was a trauma for him. The nerve of him to encourage analysts seeking a warm, affectionate rapport with those in their care. Freud was often seen kind of like very one-sidedly, I think, by classical analysts. They didn't remember that Freud used to go for walks with patients. He would give them cigars. He was quite a wonderful human being. But the way analysts interpreted his stance, I think, was really going overboard. I like that, working with patients and affectionate rapport. Very important. I mean, you can't cure people by caring about them, but you can certainly hold them. And the analytic situation is a caring, holding environment, which Winnicott talked about. And gratification doesn't work because the reason being is that, if you gratify, you don't get the underlying. Many people have been loved. Love does not the love cure doesn't work. This kind of love cure does work, but it's in a special circumstances within the analytic relationship. And Spotnitz said it's going to be an emotional interchange between patient and therapist. I give the example down one of the other talks that are on here. I think it's the first or the second talk where a patient came into the room and he said, "Do you live here?" And I said, "Oh, that's an interesting question. What thoughts do you have about that?" And he said, "Well, you see me at 7 o'clock in the morning. If you had to walk here, it's one thing. And if you had to come down from upstairs downstairs, that's another." I said, "Well, what would the difference be?" And he said, "Well, if you had to walk here, it would make me feel real special." So that was a transference. And his transference, wanting to be special, because he probably, the transference would be that he wouldn't expect me to feel that way about him, because he wasn't felt that way when he was growing up. The transference resistance would be him wanting me to gratify those feelings in treatment rather than remember them. That's what the transference. I'm going to give you some technical terms which you may or may not be aware of, but those are two. The transference is ubiquitous. We all have it, and we project it onto the therapist. When the therapists, hopefully they don't act and behave the same way that the original objects behaved with the patient. Another one is countertransference. So, if when the patient asked that question to me, "Where do you live?" and I had an uncomfortable feeling about it because I didn't know how to answer the question and felt like you shouldn't answer questions, or you should, and I was in a dilemma, what do I do? I might just phase out and zone out, and that would be a countertransference reaction out of guilt about thinking that you're doing the wrong thing by not answering the question, for instance. Some misconceptions about psychoanalysis. Frequency. There aren't any requirements for frequency. Thank goodness. Back in 2002, New York State came out with a licensing law from psychoanalysts. So there are no frequency. I happen to be a member. I went through classical analysis, so this is not sour grapes. I'm not saying, yay, frequency is no longer necessary because now I don't have to do it. I did it. I did the whole routine, and it was very good, helpful sometimes, but also sometimes it was a traumatic experience going through psychoanalytic training. But the idea of frequency, Spotnitz said, frequency is also against the person's development because it's too stimulating. So the idea, first of all, I don't know about the idea of saying that somebody has to come 2 or 3 times a week anyway in training programs. I think, why not ask them how long they want to come or how often? You might get some good diagnostic kind of ideas about if the person says, "Well, I'd like to come once every 2 weeks." Well, what does that say? Rather than whatever. So, but the program is 2 or 3 times, and then you have to be chosen. So that's one misconception. Don't have to do it. That's why I said it in the beginning. And since I am a classical analyst, but I'm also a modern analyst, so I'm not a classical analyst in the sense I believe in psychoanalysis, not like it's a religion, but I like doing it. But I wrote a letter to the New York Times as a member of the, not as a member, but as I am a member of the International Psychoanalytic Association. And despite that, I wrote the letter anyway. I knew they wouldn't agree with it, they didn't like it, but and it was published stating that frequency should not be part of an essential ingredient in psychoanalytic training. And another idea is you don't have to be a doctor or a psychiatrist or a social worker, MSW, now to be reimbursed. With a new law, you can have any master's degree, as far as I know, any master's degree to get into a psychoanalytic program, and as long as you adhere to the requirements of the training, the private psychoanalytic training institute accredited by the state of New York. I just went to one meeting of one of those institutes, the Center for Modern Psychoanalytic Studies, and they had a conference over the weekend. And it was interesting. They had a good application of modern psychoanalytic principles there. I walked into the session late because I was actually working on a video, and Dr. LaCourcia said to me, "Oh, you have a late resistance." So I sat down and listened for a while, and at some point I said, I felt annoyed when you mentioned my lateness. I wanted to say that. And he looked at me and he says, you did very well. You did the assignment. I don't think you did very well, but you did the assignment, you came, you listened, and you told me you were annoyed, so I could understand why you'd be annoyed. That's a good modern analytic intervention. Didn't chastise me. He did mention it, and it worked out well. And there was another intervention that Dr. Holmes made when people were complaining about the cell phones, people not turning the cell phones off in the conference. One person stood up and protested rather vehemently about the fact that how could analysts do such a thing, leave their phones on. I wasn't there, but this was reported in the workshop that I had. And Dr. Holmes said, "Well, listen, this is my responsibility. I really should have gave this announcement in the meeting that I'm having right now, that people please turn off their phones." So she took on the weight of the responsibility for that, which was an interesting analytic intervention in a mass group. And another thing that was actually fascinating was how Dr. Stephen Ellis applied psychoanalytic interventions, modern psychoanalytic interventions, with a group of in an agency that often works with many people who are on Medicaid, and it's a very difficult situation being in an agency and working with that kind of demand to produce results. But he was very good reception about how the techniques and how he could train people to work with a situation like that. I had a supervisee, James, who also was able to bring that work to the agency. He had a hard time explaining modern analysts because they didn't know why you could be sitting in a room and not doing too much, like talking too much. You're not talking. Well, he was listening. That's the best intervention you can have. Modern analysis to listen. So I want to give credit where credit is due. And Dr. Jerry Lucas trained me. I've with him for many years. He was the head of the Institute for Modern Psychoanalysis, one of the first graduates of the Center for Modern Psychoanalytic Studies, and also he went from the Institute for Modern Psychoanalysis into what is now the School for Training in Effective Psychoanalysis. So he was a wonderful man. He ran a group, which I still belong to, where you talk about everything that's on your mind so that you can learn as therapists all your countertransferences and resistances, so you can have the courage to talk. If we don't have the courage, how can we help our patients talk? It's much harder to talk in a group if you're a therapist, because you just have to be on top of it all, It's a great group. And Dr. Marie Lucas, I also wanted to thank. She worked with a patient and the patient hid behind a chair for 3 years, behind the couch, and became a very functioning person after Marie was able to tolerate that. So how's that for joining the resistance? Probably the patient couldn't talk because she most likely had a very intrusive environment, and Marie was able to tolerate that. So Marie, thank you very much. Next time I'm going to talk about this is therapy for the heart, the emotions, and I hope you can join me. And I'm going to talk about about the tapes of infants, mother-child interactions, and how those interactions could predict emotional disturbances a year later with consistency. Talk about emotions and therapy for the heart. That's all about emotions and emotional response to your baby. It's not about the intellect. And also, please I want to thank you for, and you can thank me, for being here. And I wish you would, if you could, leave a comment about this video on the comment section on the YouTube there's a comments, and you'd like to subscribe to this channel, then you you can open up an account very easily by way on YouTube, where they have great music, and you could subscribe, and then you can get automatically when I put something up. It's, I think, maybe sent to you. I'm not sure, but anyway, if you could make a comment, subscribe, and again, thank you. I'm going to sign off right now, and I look forward to talking to you again. All right, thanks a lot.